As you know, my name is Jose Shapusnik, together with Lisa Marsh and Gita. I can't never pronounce her last name, so I'll say Gita. Her last name is just as bad as mine. We co-chair the Youth Special Interest Group. We are delighted today to have as our presenter Dr. Katherine Elkington, who is a licensed clinical psychologist, is an associate professor at Columbia University Department of Psychiatry, and she's also a research scientist at the New York State Psychiatric Institute. Dr. Elkington is the director, in addition, director of the Center for Behavioral Health and Youth Justice, as well as the training director for a T32 postdoctoral fellowship. She's a leader in the study of the prevalence, correlates, and prevention of mental illness, substance use disorders, and HIV risks, particularly among justice-involved youth. Her most recent work has focused on the development and evaluation of implementation interventions to increase access to behavioral health and health services. She has 3 R01 or R01-like funded studies by NIDA and the National Institute of Mental Health on building cross-system relationships between justice and community treatment systems. Dr. Elkington, the floor is yours.
Thank you very much. And it's really great to be here. So thank you for inviting me. Tonight, I've got nothing to disclose. And before I get started, I want to just acknowledge the funding agencies, NIDA and NIH, that have funded the work that I'm going to be speaking about today, as well as my amazing team at the Center for Behavioral. So just briefly, I'll give an overview of what I want to talk with you about today. I'll start with just giving a very brief overview of the justice system, just so that we're all on the same page. I'm never sure how familiar my audience is going to be with the workings of the justice system. And then we can, I'll just briefly discuss substance use and unmet treatment need among youth involved in the justice system, and the barriers that these youth face to accessing treatment. And then we'll talk about specifically focusing on community supervision as an area or a focal point of the justice system to address missed opportunities for accessing substance use treatment for youth involved in the justice system. And then I'll describe 2 programs that we've developed, eConnect and Family Connect, that endeavor to do just that. So very briefly, this is a very simplified schematic, if you will, of the justice system in the US. I mean, if you can just think about the main take home here is that there are 3 main components to the justice system. Once an individual has been arrested, we have here the first component, which is the intake of community supervision. And as the name implies, this is where individuals who are involved in the justice system are supervised while they reside in the community, so they're not in a locked facility. Here we have detention, which is typically, it's a locked facility. It's typically for shorter stays, either while awaiting trial or can just be for a short-term sentence post-trial. And then finally, we have secure care or incarceration, as it's referred to in the adult system, prison, and that is typically for longer-term stays. So there are arrows here, it's very intersecting. You can leave the justice system at any of these points, but also you can re-enter the justice system just as easily. And in fact, unfortunately, we do know that once you become involved in the justice system, it can be really quite hard to leave. And then finally, we have the court system here, and to think of the court, if you will, as a fulcrum of the justice system, where they're kind of directing traffic. And they're at the hinge at which point people kind of go back out into the community following court, or can go further and deeper into the justice system. And the court is oftentimes will be the location of if somebody's at a given, so say somebody's in under community supervision, if they're not able to follow their mandates or their orders and conditions of probation, for example, they can go back to court. And then at that point, the the court can sort of funnel them further into the justice system. So it works as so youth involved in the justice system have numerous behavioral health problems. I don't think this is probably new to the audience here. Studies have identified anywhere from 25 to 67% have a substance use disorder, which is substantially higher than we see among youth in the general population. And data suggests that 75% of juvenile arrestees have substance use or addiction involvement within months of their arrest. And unfortunately, but it's also something to be mindful of, comorbidity is the name of the game. And so 35 to 60% also have a co-occurring mental health disorder. We also know that as you move further into the justice system, so from community supervision, detention, and then placement, rates of disorder increase. And so with greater justice involvement, we have greater behavioral health needs. Why do we need to pay attention for looking at substance use and behavioral health problems, broadly speaking, among justice involved youth? Well, as with other youth, they're really associated with numerous poor outcomes, and particularly problematic substance use into adulthood. Studies have shown increased sexual risk behaviors among this population, reductions in academic achievement, increased suicide risk behaviors, early mortality. And kind of the sum of this is that it results in higher rates of reoffending and violence, and just makes it harder and harder for these youth to exit the justice system. And so identifying, linking, and treating substance use and comorbid mental health problems then is really important to improve both long and short-term outcomes for these youth. This is probably a framework that most of you are familiar with, certainly Dr. Shavhaznik. So this is the eco-developmental framework. And looking at this to see what is the context of substance use and justice involved youth. Why do we see such high rates? And so looking at in the various interconnecting systems of risk, work by myself and others has identified that the risk factors that we know to increase substance use among sort of general adolescent populations, for example, living in neighborhood characterized by high poverty, violence and crime, or a high community substance use burden. Then similarly within the families that have characterized by greater conflict, less parental support or monitoring, poor communication between parents and children, and then caregivers' own mental health, substance use and trauma. These things have all been associated with increased substance use among youth generally speaking. And we see that the rates of these risk factors are much higher among justice involved youth, and so potentially is contributing to the higher rates of substance use that we see. Now, as these youth struggle with substances, oftentimes what happens is they become detached from potentially the protective mechanisms within some of these systems, and so as they detach from school, from their family, from peers, as they're struggling with substance use, a lot of times it's the juvenile justice system that then becomes the system that kind of captures these youth and is then in a position to both identify and link and even treat these with respect to. Now, there are evidence-based substance abuse treatment programs that have been specifically designed for youth involved in the justice system. I did a quick review and found that there are 15 evidence-based programs. They're focusing on either substance use exclusively or a combination of substance use and mental health problems. If you remember, comorbidity really is predominant in these youth. And there's both programs that work with the family as well as just youth by themselves. So these programs do exist. Nonetheless, even after identification of need, between 50 to 90% of youth involved in the justice system do not make it to treatment. And so many of those same risk factors that we see that are common in the lives of these youth that would promote substance use are also those similar risk factors that can serve as barriers to treatment. And so here, in addition to some of the others perhaps within the family system, such as stigma, low perceived need, lack of insurance, in the neighborhood level, few available youth services, particularly for substance use, wait lists, lengthy wait lists. And so these are all things that serve to further limit the ability of these youth to access treatment. One particular system that I think has not been as well studied is the juvenile justice system, and it may be a system that is potentially ripe for intervention. And so really thinking now, the justice system, as I described to you, is pretty large and has a far reach. But I want to focus today's talk on the community supervision and sort of piece of the justice system. So that's the front end of the system. There's a couple of reasons for that. Primarily over the past 20 years, we've seen some really important justice reform that's focused moving youth from the locked facilities or secure care into more of a community supervision focus. And we've seen that the proportion of youth over the past 15 to 20 years that have been confined is decreased by 70%. And as a result of that, the overwhelming majority of youth who are somehow involved in the justice system are under community supervision. And so working with community supervision agencies, you really have broad reach. And it allows us to identify those youth who are likely not linked to services in the community. We do know that for many youth, their contact with the justice system can oftentimes be the first time that their behavioral health problem or the substance use problem is identified. And also community supervision, part of their mandate is they're charged with community safety and preventing recidivism. And they do that by linking the youth to services as necessary. And so thinking about substance use on the causal continuum of recidivism, or at least strongly associated, and I know that relationship is complicated, but it would be considered part of the role of probation, community supervision, to identify and link youth to substance use treatment in particular. So what are youth community supervision agencies doing? So there was a recent national survey that explored, that sent out surveys to over 3,000 community supervision agencies from 20 states in the US to really understand exactly that, what were, with respect to identification, linkage and treatment, what was happening in community supervision agencies. So here you can see, for the most part, they're screening, they are conducting screening at intake. And the majority of these, I think it's about 87%, we're using an evidence-based screen, which is really lovely and heartening to see. Then as we go further sort of down the types of treatment that occur following screening, fewer, about 1 in 4 provide a clinical assessment on site, and then even fewer provide on-site treatment and mental health. And what this suggests is that for the most part, for youth who are on community supervision, to access services, it means that they have to go into a different system. And I know that there is not a sort of a behavioral health system or community a behavioral health system, so to speak. It's not this tight, organized entity, and it's very disparate. But for the purposes of just kind of thinking through how we move youth from the justice system in order to access care, it's just kind of helpful to think of it in these two different spaces. And so thinking of it in those terms, youth under community supervision then need to go into a different system in order to receive care. And what happens oftentimes is youth get lost in the shuffle. And so these are data that Jenny knows well. These data come from JJ Trials, which was a large NIDA-funded multi-state study of community supervision agencies, and the focus of the study itself was to increase access to evidence-based services for youth. And it was an implementation science project. So what we did at the beginning was get a baseline picture of what was going on in community supervision agencies that we're working with before we began the intervention. And a way of doing that and really understanding how youth are getting from one system to the other, we were able to use Behavioral Health Care Cascade. Some of you may be familiar with it or may have recognized it from from HIV Care Cascade, which is where this was borrowed from. There's also an opioid care cascade. And essentially what it does is maps out the different stages an individual goes through, from identification through to treatment initiation and retention. And then at each step along the way, you can follow an individual through, and you can see where people quote unquote fall off the cascade, and it identifies points for intervention. So here you can see that in a sample of just over 8,000 youth who are on community supervision, most of them were screened. Again, we're seeing that their screening is pretty good. There's definitely room for improvement, but 70% is not bad. And particularly if you think about 20 to 30 years ago, the main epi studies, the conclusion was that screening had to occur, and so because it just nothing was being done. So we can see there that the field has progressed. And then of those, about half were identified as having a substance use need. Now, certainly it's not a diagnosis, so this is just screening, but some indication that further assessment or treatment might be warranted. But here you can see the massive drop-off. And this is the point of referral. And about 1 in 5 youth of those youth who needed treatment didn't, only got a referral, so 4 out of 5 didn't. And then what we do see following that is once they are referred, youth are likely to go. But if you think about the total number of youth who were identified as in need, we have about 1 in 10 who actually make it to treatment. So referral here, we can see that this is a point of intervention, and prior work has shown that referral is an act that's something that probation officers do, and it's influenced by several factors. From an organizational standpoint, probation officers who perceive greater support from their supervisors, who perceive their organization to be innovative or flexible, and also recognize and identify that referring to treatment is both important and relevant to their role of a probation officer. Those probation officers are more likely to refer. Similarly, though, also probation officer knowledge and attitudes and beliefs are associated with referrals. So whether or not they perceive the youth to actually have treatment need, we see that there's influenced by referrals are influenced by youth gender, age, and race ethnicity. And also the probation officer's comfort with or knowledge of clinical problems, and also the behavioral health system, broadly speaking. Do they know where to send a youth that they've identified as having a specific substance use problem or behavioral health need? And so taking into consideration sort of these issues that we saw, particularly thinking about the system at the level of the system, we developed eConnect to address some of these missed opportunities. So it was drawn originally from a project Connect, which was developed by Gail Wasserman, and we adapted and augmented it. And so essentially eConnect is a web-based application that's installed on tablets, and it seamlessly combines screening for suicidal and related behavioral health problems among youth who are under community supervision. It then classifies the youth based on their clinical need. So it kind of allows for triage and important in these resource limited settings. And then importantly, once clinical need has been determined, it identifies in real time, very county specific referral decision-making for the services based on the clinical need that's been identified. We call these the referral pathways. And it also removes the PO discretion because regardless of how the youth presents, the screening algorithms and the resulting behavioral referral pathway are the same. And so we wanted to examine whether or not eConnect does a better job of identifying, linking youth to care compared to what the probation officers were doing before their kind of standard treatment. We implemented eConnect in 10 New York State counties. So here you can see we're kind of well spread across the state. Snowing now, we're expecting heavy snowstorm. So there are basically 5 activities that go into eConnect when an individual completes the screen. So we'll go through a couple of them, but this is sort of a slide that we show to probation officers when we're training them so that they can see the workflow. So the first, the main step is that the youth completes the screen by themselves, and it's voice-based so that if there are any reading or literacy issues, the youth is not impeded by that, and they can just sort of like press the question and they hear it on the tablet and they can answer. The screen is made up of subscales from the GAIN short screen, the internalizing and the substance use subscales, as well as we added some very specific items from the GAIN inside behavior. And we also added a couple of response options to get at more nuanced time frame. So typically the game asks in the past month and then in the past year. And we added past 2 to 3 and 4 to 12 months. And that was really for us to get at the clinical acuity so we could identify and triage, identify risk classifications. We didn't assess externalizing disorders, crime or violence disorders, subscales. We didn't use those, A, because they're externalizing disorders isn't particularly because it's measuring conduct disorder, isn't particularly sensitive for a population who are already justice involved. And crime and violence, typically youth on probation may not be as reticent, or they may be a little bit reticent to admit those behaviors. And so we excluded that. So then and these were just examples of suicide. So then after the youth has completed the screener, it's scored and it determines 3 classifications of risk, based on the combination of the presence of symptoms. Class 1 are those that are imminent risk. So those are you who are acutely suicidal. Class 2 are for those youth who are, they've got some substantial mental health and substance use treatment needs. And also they probably have a recent history of months. They're not acute. They probably wouldn't be admitted if you took them to the ER, but these are for youth for whom nobody is particularly comfortable with letting them go home. And then finally, we have class 3, which would be, we refer to our standard behavioral health referral. So youth with mental health or substance use problems in the absence of suicidal behavior. And what was important about the classes is that it dictated response. So class 1, the youth was seen that day immediately. Somebody would come to probation, mobile crisis, or the youth was sent to the ER. Class 2, where the youth is seen within 72 hours. So they may go home, but they have an appointment within 3 days. And then obviously class 3 would be just the standard referral. So then finally, step 3, after the classification has been determined, within a given county, the tablet then presents to the probation officer the specific steps that they need to go through in order to refer that youth to the specific designated clinical care that's. And this is very, very prescriptive, right down to who you should call, what the number is, what the fax number is, and et cetera, et cetera. And so then it allows the probation officer, it removes that that concern where if not really knowing where the youth is supposed to go because of the clinical. And we call these things the referral, the pathway. And importantly, before eConnect goes into the field, we spend a considerable amount of time. We bring the stakeholders within a given county together, behavioral health and juvenile justice. And this is where we really begin that kind of collaboration piece. We decide where the youth are going to go based on the classification of risk, and not just where, but how. So who's going to come? How are they going to get there? Who's going to transport the youth? And then at that time, the behavioral health partners will agree to and commit to seeing, particularly, for example, the class 2 youth. They'll agree that they can see them in 72 hours, and so they may jump a wait list, or but you get that level of buy-in and agreement. And that was really important. And that happened for a couple of months. And once that's agreed upon, then the pathways can be generated and programmed into the tablet. And then obviously we, one of the things that's great about the tool is that following the completion of the screener, it creates a PDF that can be printed out, and on that it serves as a referral form so that the youth can, the probation officer can then send that over to the funding clinician and or hand it directly to mobile crisis if that's used to the youth. And it contains the items that the youth endorsed. And so what really helps for clinicians is then they can understand why that youth is coming to see them, why they, and they can see exactly what were the symptoms that they endorsed. So I'm going to move on to the findings that I have right now, but before I move on to that, does anybody have any questions? I forgot to mention that you guys can absolutely interrupt me as I go through if you have any questions or if anything's not clear. Nope, hearing nothing, I will go on.
It looks like there are questions in the chat box.
Oh, right.
The first one is from Dave Atkinson, and it says, in this ecosystem model, are there estimated weights for each component of the model? It varies kid by kid, but I was wondering on average.
So that's a really great question. And I don't know that anybody's looked at that specifically by sort of generating a measurement model that would be able to assess what are the kind of the most important or influential aspects of the system that influence behavior. I mean, I think that the theory, and Dr. Shafaznik, jump in at any time, but the theory would be that sort of the more proximal systems, so those that have more influence, and then sort of it goes up from there. And then the second question is, in the youth, about 450,000, but that number is decreasing to about 250,000, but that number is decreasing, but about 250,000 youth are on community supervision. I think it's around 400 if you count the youth that are involved in the court. So they're technically in the community, but they may not necessarily be under community supervision, but they're certainly justice involved at that time, and they're in the community. Okay. It used to be higher. The numbers are going down, which is a good thing. So what did we find? So looking specifically. So we looked at this for the purposes of this presentation. I limited the analysis to just those who endorsed a score of moderate or above on the substance use subscale. So that's typically endorsing 2 or more symptoms, and I believe there are about 6 items on that subscale. And that's typically the flag from the gain that would indicate that someone needs further assessment. So of those that we had a sample of 650 youth that were screened at baseline. So of those, 250 indicated a score of moderate or above. So that's about 38% of the sample, and that is similar to what some of the other studies. I know Gail Wasserman, for example, she did a study of substance use looking at of disorder, looking at rates at intake, detention, and placement. And so she saw around 40% for those with disorder at intake and probation. So here, using the behavioral health cascade, you can see the rates of screening, need identification, referral, and initiation to treatment. The gray reflecting what was occurring at baseline, and then the sort of the maroon, I guess, the red is the eConnect period. These data were drawn from administrative records. And so at the beginning, the community supervision agencies weren't formally using an evidence-based screen for substance use and mental health problems. They were using something called the YSIG, which stands for the Youth Assessment Screening Inventory, I think. Doesn't quite make sense, but it's a validated evidence-based tool for recidivism. And part of that, they explore mental health and substance use needs, but it is certainly not evidence-based for mental health or substance use identification. And it's also sort of based on the PO's observations and impressions. The youth does not complete any sort of aspect of the YSIG as they do with the eConnect. So they're 2 quite different ways of ascertaining need, but nonetheless, so we see we're sort of similarly identifying youth with any substance use need, and about half or just slightly more have unmet treatment need. But where we see the biggest impact of eConnect, we see here we're able to get youth referred. We increase that rate of referral by an odds of over 5, and then similarly that once these youth are referred, so each step is conditional on the prior. So of those with unmet need, 87% of those were referred. And of those who were referred, 86% were initiated treatment. So that's an increase of an odds of 18 times more likely to initiate treatment compared to the baseline period. So we can really see that the impact of eConnect here. So just for everyone's interest, like this is just the rates of the different classifications of risk that we found among those that endorse substance use. So we had about 21% of these identified as being in crisis. So identifying either a current or at least recent suicidal behavior. So 1 in 5 is pretty high. And then about 36 or a third had substance use that met the threshold that we would suggest would require a referral to treatment. Going back to the idea that there are sort of some of the influences on referral, and there's been work shown gender, race, ethnicity can influence whether or not our youth refers and then subsequently initiates treatment in probation. And at baseline, we did see that, unfortunately. So primarily, we saw non-white girls were much less likely to be referred for treatment, particularly compared to white girls. And just because the data are have been from administrative records, with the way in which we're able to draw them, that they are heavily de-identified. So we don't have a more nuanced, unfortunately, variable of race. It's just white versus non-white. And that was done so that to really help protect the youth. In some of the counties that we work in, they really are quite small. And so kind of combining a lot of demographic information with some dates potentially would be quite identifiable. So these were steps taken to protect the identity of the youth. But what we see when we implemented eConnect or an eConnect phase is that not only do the rates of referral go up, but we really do minimize that discrepancy or that inequity by race and gender. And so here you can see that similar referral across the board among those who are in need, which is a really nice product of a systematic screening and linkage and referral. So then we talked about the justice system, but now I really just want to briefly focus on the family system and thinking about how the family can serve as a both support, but also a hindrance for youth getting into treatment and care. The importance of family involvement in treatment seeking and engagement has been well established. And we know that it consistently promotes positive treatment for youth. And so with respect to youth on probation, engaging the families at the point of identification of treatment, so in the probation system, it may serve to increase caregiver engagement and support of the youth treatment in the behavioral health system, and hopefully then increase youth treatment in attendance. However, we know that engaging families at any stage of the youth juvenile justice system involvement is very, very difficult. So we wanted to explore a little bit why that might be and what are some of the factors that influence whether or not families choose to, or not choose, but whether families are able to take advantage of substance use services that have been referred to them by treatment, by probation. And one of the things that really emerged was this idea of being engaged. And so we looked at, first of all, we did a series of interviews and focus groups with youth and caregivers. We interviewed them separately and then conducted focus groups with probation officers and substance use treatment providers that were in the same county. And so a big theme that emerged from the caregiver interviews was this general distrust in the system, and the system broadly speaking, so juvenile justice as well as behavior, in the sense that they really weren't in it for the child or the family's best interest. The system doesn't really care about anybody. Okay, this is going on and we're going to go over there and just split everybody up. So why should I talk to them? Why would I let my teen go to treatment? And so this is a concern that a mother had about letting her child go to treatment. Providers recognize and parents echoed the sense of fear and shame that families may experience or may have about what it means to have a child who is using substances. fear of what we're going to hear in the treatment. So not only the child is going to talk about their own use, but then also potentially what else is going on in the family. And then the mother here talking about the stigma. Everybody tries to focus on the parents. They try to find out where the problem could have started or what could have caused it. But no, I don't beat my children. There's no sexual abuse. I don't drink. I don't smoke. Also, providers recognized that there were family relationship difficulties, particularly between the youth and the caregiver, that served as barriers for the youth engaging in treatment and care. And one provider noted, they being the parents, they want to slow down the car and dump the child here and keep going, which is understandable because they're done and they have very little hope. And so these are parents of teenagers who it's difficult at the best of times, but they have had difficult relationships for quite some time now. And then finally, the recognition that there was overburden within the family system. It's limited lack of resources and essentially bandwidth in order to support. As a probation officer notes, the treatment system's expectation that the youth maybe attend a program 3 times a week. This is dependent on a mom who works overnight. They don't have the money in their grip. And so just recognizing the multiple competing demands on a family and sort of thinking about Laszlo's hierarchy of needs, youth substance use treatment might not necessarily be up there among the other things that the family has to contend with. So thinking about all those things, we developed Family Connect as a way to really address and get over some of those barriers and help support the family as they work with the youth to get them into treatment. And it uses a linkage specialist so that we're who works closely with the families, but also works with the probation officer and the behavioral health provider in order to kind of increase that coordination. So everyone's on the same page, everyone's sort of all the switches are turned on. And the idea here is that with using a linkage specialist, we can decrease the probation officer burden and improve coordination in that way. And probation officers' plates are very full. They're doing multiple things, managing court, going out into the community. And so that extra step of really working with families and being able to coordinate with behavioral health in this way, we thought it might be better if we could utilize somebody that was their specific job. So developed Family Connect, working with a CAB comprising families and probation officers and treatment providers. We essentially developed a linkage program that was focused on 5 tasks, and it was to be completed by the family and with the linkage specialist. The task could be completed in any order with the exception of the first, which is really to develop that working relationship, to help the family, particularly the caregiver, recognize that linkage specialist was on their side, that they could be trusted. Again, thinking about that distrust in the system, which honestly has been, these families really have kind of learned from past prior negative experiences. And so to really try and overcome that piece. And then going through any of these other issues as they may emerge. Clarifying the need for treatment, that the youth does have a treatment problem or substance use problem, and really getting at those perceived barriers to treatment, that stigma, that what are they going to talk about, what's going to happen, are they going to separate the family, what happens if they describe something else that's going on. So some of that real concern. Addressing potential relationship ruptures between the child and the caregiver, getting them to agree to work together to support the kid in getting to care. If that's not possible, then we would have made a referral for family therapy. Family Connect was a linkage program. So we had to walk that fine line and really not engage in sort of a family therapy with the caregiver and the youth, although we recognize a lot of those dynamics and those pieces that we had to do. And then obviously we're going to address concrete obstacles to enrolling in treatment, transportation, insurance, that sort of thing. Identifying programs that would work for the youth. We always recognize that if the perceived barriers had been addressed and if the caregiver felt really comfortable or felt comfortable about going to treatment, the concrete obstacles were very easily overcome for the most part. So when someone says, oh, transportation is an issue, it really is. But if somebody wants to go to treatment, you can figure out transportation. And then obviously we facilitate that enrollment and that treatment retention and working with the. So we were able to see, just briefly, it was a small pilot. We enrolled 18 youth and caregivers, and then we compared it to a historical control. So 6 months compared to the prior 6 months. And again, we pulled these from administrative records. And so we were able to see that among youth who had a substance use problem specifically, we were able to we had strong rates of referral to treatment, which obviously is not surprising. It's the name of really the focus of working with the linker specialists. We were also able to get youth to attend at least an intake or complete the intake process. We weren't as great at getting the youth to stay in treatment compared to what was compared to the control period. So on average, the linker specialists worked with the families for about 5 months, so it's pretty intense. And they normally met about twice a month on average. And then we conducted some just very brief exit interviews with the experience of eConnect, and two key things emerged about the importance of eConnect. The first was the linker specialist role in really improving communication between the youth and the caregiver, particularly for the child. My mom needed another adult to be there so she'd understand, and the child really felt like the linker specialist was able to help them explain and kind of describe what was going on for them. And then also just the linker specialist providing just education about treatment and how it can be useful and as a tool for the family as opposed to something to be afraid of, and just the caregivers' appreciation of that. So in conclusion, we know that youth involved in the justice system have a disproportionate burden of substance use disorders and comorbid mental health, and that their use of needed services remains low. So using streamlined procedures in the context of an integrated juvenile justice, behavioral health, and family system is really key to improving access to care, and sort of working at these different levels. In particular, when you have automated protocols with oversight, so we provided feedback, obviously, to the counties that we were working with. We were able to remove system and probation officer related bias through referral, which I think is huge. Also, too, that clinical decisional support that was provided by a technology that was on the tablet really allowed the probation officer to, who we frequently told by probation officers that they're not trained as clinicians, that this is not their role and they don't feel comfortable there, but it really enabled and empowered probation officers to not only feel comfortable screening, but then knowing what to do once the youth have flagged on the screen, knowing where to send the youth and how to send them there as well. And then finally, that embedded having a linker specialist who can work with the family one-on-one and can overcome some of those individual and some of those system level barriers that can serve as barriers to treatment access. I think is obviously really important. And the approach, I think, is potentially generalizable to other parts of the justice system, as well as other youth serving institutions. So thinking about re-entry from secure care, again, that's a connection that needs to be made for community treatment. And so a similar eConnect approach could work there. Also thinking about school to treatment systems. So now moving out of the justice system, but thinking about how schools can facilitate that connection. Again, eConnect or Family Connect, working with those families, be really important and effective. So what's next? I think documenting and understanding what promotes the sustainment of eConnect. So we're stepping back now in New York, and we're letting the counties run eConnect by themselves. And we're providing kind of limited technical assistance and support. So we're really exploring and studying how easy something like eConnect could be sustained. Also focusing on that right side of the cascade, if you will, kind of more of the treatment retention and getting youth to stay in treatment. And that may be facilitated by potentially integrating Family Connect and eConnect to really boost the effects of both. And then finally, we need to continue to remain vigilant to the training trends in substance use that we see among justice-involved youth, so that we can address both those treatment and prevention needs. And I will finish here with this is data from another study that I have. These are justice-involved young adults, so they're caught in a court diversion program. And we just looked at their substance use history over, this is lifetime substance use, and we did a quick latent class analysis just to kind of see the patterns of use. And obviously polysubstance use is the name of the game. The majority of youth, you can see here, are using alcohol and marijuana and really not much else. And so but we do see two other classes where cocaine and then obviously opioids are becoming more and more prevalent. And so this to me speaks of these emerging trends. We actually didn't see methamphetamine, which is great. And maybe that this was in New York City. And so for this population, we may not yet see it, but I'm sure it's on its way. But again, we are seeing the emergence of opioids and benzodiazepines as well. And so this really indicates that prevention for justice involved youth with respect to opioids is really key, particularly for these two classes, the red and the green, if you will. And then obviously this represents a group in need of probably likely in need of treatment, but really thinking about how we can prevent opioid use from either starting in the cases of the second latent class or from becoming problematic as in the case of the first. Thank you very much.
Thank you so much, Dr. Elkington. And I know that there is a question in the chat. David Atkins.
Yeah, I was just briefly, I was asking about, Maslow's hierarchy of needs as you're assessing what the family will do. I was wondering, is Maslow's hierarchy, is that evidence supported, or were you more saying that this is an informally assessing, their
needs? It's more informal, but just as a way to give folks a sense of what the families are juggling. So you're thinking about the parent who is in a lot of instances the parents are overemployed, so they're working multiple jobs, and because they their financial needs are such, and so the ability for them to take time from work, for example, so that they can take their child to treatment. There's just like multiple competing needs that we have to be sensitive to.
All right. Yeah. All right, sorry. I guess that was, because they were kind of, it's an informal usage. You're not formally assessing.
Yeah, sort of like paying rent is more important for the mom at that point than getting their youth in treatment.
Anyone else would like to ask a question? Just go ahead.
Can you hear me? George Woody from Philadelphia. What are the caseloads of the probation officers in I've worked with adults in Philadelphia coming out of jail, and the POs have caseloads of about 100, and they have to prioritize the time they spent with the most severe and the least severe. Don't get much attention, and there are a lot of addicts who severity is like danger to the public, like armed robbery, stuff like that, and most of them aren't involved in that. They're smaller crimes. I'm curious, what is the caseloads?
It really varies depending on the size of the county. So some of them are more rural and they just don't have huge population size, generally speaking. So you can get anywhere from a caseload of 50 to some of them have maybe 7 or 8 on their case. Some of them have 75. It really does depend, and it also depends on whether or not the county it has deals with PINs. So in New York, we have it's called persons in need of supervision. Other states maybe call them CHINs or FINs. And what those youth are, they haven't necessarily been arrested, but they're kind of on the banana peel, if you will, and they get referred to probation either by the family, where the parents are like, my child's out of control, they're staying out late at night, I can't, I don't know what to do, or the school where the youth is consistently truant, there may be issues there. And so if a probation officer has a caseload of those that are arrested and sort of court involved, or that are on PINs or diversion as well, so it can really the caseloads can really vary. But essentially, to your point, is that they are really busy, and so their caseloads can involve managing the court and making sure that they either attend court or got documentation that's relevant for court proceedings to move forward, that they have to do community checks, and so they go visit schools, they go visit youth at their homes to make sure things are going well. A lot of the probation officers that we work with, they actually really go above and beyond. So oftentimes they'll take youth to a basketball game, or it'll be like a high school game, and they'll a couple of them, and they go with them there. And so they sometimes can step into that parental role as well, providing kind of a more of, not parental, but more of kind of a supportive mentoring adult figure. So they are really busy. And then when they are faced with families that have additional needs with respect to getting youth to treatment and care, it's hard for them to be able to kind of take that time to work with the family and figure out what's going on.
Mhm. Thanks.
We have time for one more question. If anyone has one more question. If not, Dr. Elkington, I want to thank you for that amazing work that you're doing and for this presentation. I personally am very excited by the ability of your interventions to increase, to move children along the treatment cascade. That's really quite remarkable. I want to ask you, would it be okay with you to share this recording as well as your slides with the group?
Yeah, absolutely. That's a problem.
Well, that's wonderful, because we will do that. Thank you so much. Keep up the great work that you're doing. It's very important.
Will do.
I see Chad, Jenny Bekan. Those are very hopeful findings. Hopeful is the right word. We need hope in this field. So thank you so much, and keep safe and healthy. Bye.
Thanks, guys. Bye-bye.